want to thank the organizing committee of the Third World Critical Long Day for the effort and the commitment with this initiative. Second, I want to thank scientific societies involved from Europe, from North America and Latin America, and of course from Colombia. Is a special meaning to participate in this event. And I want to present the session number 6. In this interesting session, we have 3 main lectures about the winning of the long-term mechanical ventilation from Dr. Oscar Peñuelas from Spain, the new therapeutics targets in acute lung injury from José Ángel Llorente, and finally, the management of fungal infections in lung transplantation by Dr. Ricard Ferrer Roca from Spain. And finally, we will have the session of questions and answers. We have the opportunity to introduce Dr. José Ángel Llorente, who is the chief from the intensive care from the Hospital Universitario de Getafe de Madrid, y es investigador de CIBER de enfermedades respiratorias de España. Welcome, Dr. Llorente.
Thank you very much. I'd like to thank the organizers of this meeting, especially Dr. Cardinal, for the invitation to participate with this talk on new therapeutic targets in acute lung injury. I'd like to convey a few messages that I will summarize at the end of the talk, and these are on the concept of acute lung injury and potential new therapeutic targets. First of all, what do we understand by ARDS? We have to emphasize that one thing is the concept or the definition of ARDS, and a different thing is the diagnostic clinical criteria. So the so-called Berlin definition of ARDS is not really a definition. It's a set of criteria that we agree that is able to identify patients that meet a definition that we have defined before. So what do we understand by ARDS? ARDS is a diffuse acute lung injury associated with a predisposing risk factor characterized by inflammation leading to increased pulmonary vascular permeability and loss of aerated lung tissue. This definition is characterized by different hallmarks, both from the histological point of view and from the clinical point of view. The clinical syndrome is characterized by hypoxemia, bilateral X-ray opacities, and some physiological derangements characterized by increased shunt, increased physiological dead space, and decreased respiratory system compliance. And from the morphological standpoint, we have to define ARDS as an entity characterized by edema, inflammation, formation of hyaline membranes, and alveolar hemorrhage. Indeed, this definition fits what Asbo and collaborators tried to define in the first report of 12 cases of ARDS in 1967. They reported 12 cases of refractory hypoxemia that presented acutely after different types of insult, abdominal trauma, viral infections, pneumonia, pancreatitis, that had a high mortality rate. And in the autopsy of those patients who died, they found atelectasis, hemorrhage, and formation of hyaline membranes. And from this first description, the concept or the definition of ARDS has not really changed, and we all agree that this is what we mean when we say ARDS. However, we have to realize, and this is our study, and there are more studies emphasizing this concept, that when we make the clinical diagnosis of ARDS in a particular patient, we don't really, and we are very poor at defining the entity of ARDS as a clinical pathological entity. In this study, we analyzed a large number of autopsies of patients who they all had the clinical diagnosis of ARDS. one would expect that the morphological manifestation or the morphological findings in these cases were those that were described at the beginning, formation of hyaline membranes, edema, and so on. However, only a small percentage of patients, 45% overall, and even less if the ARDS is mild, certainly more if ARDS is more severe, have actually DAD, diffuse alveolar damage, at autopsy. So when we diagnose ARDS as a clinical diagnosis, at least from this design, which is of course biased because it's only patients who died, this is an autopsy study, many patients, are even more than half overall, do not have DAD, do not have the morphological manifestations of ARDS. So when we face a patient who has hypoxemia, bilateral infiltrates, a known risk factor, and we diagnose this patient with ARDS, we are not really defining a clinical pathological entity, because about half of these patients actually have different entities, not only DAD, but also they may have pneumonia, abscess, TB, fibrosis, pulmonary hemorrhage, and so on, and only a few have what we really mean when we make the diagnosis of ARDS, which is diffuse alveolar damage. So, and all these entities do not certainly share the same pathogenesis, the same pathophysiology, the same treatment, and probably the same biomarkers or risk factors. So when we conduct clinical trials, when we treat these patients, we have to know that many of them actually do not fit the criteria for the clinical pathological entity of ARDS as we understand right now. And this, the importance of this idea is underlined by different studies. For instance, this study by Calfi and collaborators analyzed blood samples from previous studies, the ARMA cohort, the study of low versus high tidal volume, and the alveoli cohort, low versus high PEEP, and they measured different biochemical variables in these serum samples, and also a large number of clinical variables, and they identified previously undisclosed, previously unknown subphenotypes within the diagnosis of ARDS. So these patients with ARDS could be classified, and the mathematical analysis underlying this study is very interesting. It's latent class analysis, so it classifies patients in different groups that we don't know a priori into phenotypes, phenotype 1 and phenotype 1 and phenotype 2, one characterized, if we were able to see the variables here, by more severe disease, higher FiO2, higher PEEP, and very interestingly, higher, a more marked activation of the inflammatory response and of the coagulation response, as opposed to phenotype 1, in which the inflammation was less marked and the activation of the coagulation was also less intense. And the interesting thing is that the mortality of these two phenotypes, which again were not known when these studies, the ARMA and the alveoli studies, were conducted, were different. The phenotype 1 had a lower mortality than phenotype 2 in the ARMA cohort, and also in the alveoli cohort, phenotype 1 had a lower mortality than phenotype 2, with a very high p-value for interaction between phenotype and treatment, and mortality. But more interestingly, the response to treatment, if the analysis was retrospectively done on these patients, considering these phenotypes that were unknown at the time of the clinical trial, the response to treatment is different. Phenotype 1 in the alveoli study had a higher mortality rate if they received high PEEP as compared to low PEEP, and phenotype 2, the opposite, had a lower mortality if they received high PEEP as compared to low PEEP. So considering these phenotypes is very important when we design clinical trials and when we test the effects of different treatments. And also the response to fluid therapy is different if you consider the phenotypes. If you compare conservative versus liberal fluid administration, liberal fluid administration is associated with a lower mortality rate in phenotype 1, but with a higher mortality rate in phenotype 2. We also try to study in more deeply this concept of the existence of different phenotypes within DAD, within ARDS. In this study, which was actually led by Pablo Cardinal, in which we studied a large number of autopsies, and we tried to define different clinical patterns before they died in patients who in autopsy had DAD as compared to patients who did not have DAD in the post-mortem study. And we actually found that different variables like the PF ratio, the peak inspiratory airway pressure, the difference between peak airway pressure and PEEP, the dynamic respiratory system compliance, were different with a quite highly significant p-value in the two groups. And if we represent in the 7 days prior to death these different variables, we found, again, these all are patients who died with a clinical diagnosis of ARDS. They all had, according to the clinical criteria, they all had ARDS, and they did not have any difference that was very obvious from the clinical standpoint. However, in this analysis, we realized that patients who had actually DAD, which is the entity we want to identify with the clinical diagnosis, had a lower PF ratio in the 7 days prior to death as compared to patients without DAD. The peak inspiratory pressure was also higher in patients with DAD as compared to patients without DAD. And also the SOFA score was higher, the platelet count was lower. So we are able to determine different characteristics that define a clinical profile of patients with DAD as compared to patients without DAD, although all have the same clinical diagnosis of ARDS. And actually, with these variables, we were able to come out with a regression model which was better for the diagnosis of DAD than the Berlin definition, which was, as we are emphasizing here, very poor to identify this clinical pathological entity of ARDS, not only clinical criteria, but also the morphological changes of DAD characterizing ARDS. We have in our laboratory studied some other issues related to this topic. We have analyzed how tight junction proteins are affected in patients with ARDS according to depending on whether or not they have DAD. And here you have SO1. SO1 is a tight junction protein, and in normal cases without ARDS, this is the normal appearance in red of the alveolar wall stained with stained for SO1 protein, and case 1, case A and case B, and here is the same pictures as above, but with a DAPI stain, which is to identify cell nuclei. So this is the cell wall, the alveolar wall, and the normal expression of SO1 in these cases without ARDS. However, in patients with ARDS and DAD, this normal appearance is lost. There is loss of the normal expression of the protein, and is certainly totally disrupted, and there is more cells in the alveoli, lumen. So this is totally changed in patients with DAD, and also not only SO1, but also other tight junction proteins like occludin. This is the normal appearance of occludin in case A and case B, which are two examples, and in cases C and D, which were diagnosed of ARDS and they had DAD at the histological examination, this normal structure is lost, indicating that probably correlating with hyperpermeability, which is the physiological hallmark of ARDS, there is a loss of the normal expression of tight junction proteins that are important for the maintenance of low permeability in the alveolo-capillary wall. So we went on, and we also wanted to study whether we are able to attenuate the inflammatory response associated with ARDS. And this study, which was started also by Pablo Cardinal in our group, we identified a number of microRNAs which are good as biomarkers in other conditions, such as cancer and many other diseases, but not so much studied in acute lung injury. We identified this microRNA, which is called 27A5P, as a biomarker of hyaline membrane formation in our rat model of acute lung injury induced by mechanical ventilation. It's really a model of Willi. So rats receiving high tidal volume had in the serum and also in lung tissue increased levels of this microRNA, and even higher if the rats developed hyaline membranes as a result of this insult of high tidal volume during the time of mechanical ventilation. So with this finding, we went to our model of human alveolar epithelial cells that were treated with the inhibitor of this microRNA 27 to see whether the expression changed, and actually the inhibitor at 3 different doses decreased the expression of the microRNA 27, and this proves that this treatment is actually effective because it has access to the interior of the cell and modulates the expression of this microRNA, and the treatment of these cells with the mimic of the microRNA 27 increases the expression of the microRNA. And also in a different model in which we used ventilated perfused rat lungs in our laboratory, we were able to show the same finding. The treatment of this preparation intratracheally with the inhibitor of microRNA 27 led to a decreased expression at different doses, and treatment administered by intratracheal route in this lung preparation was associated with increased expression of microRNA 27. And then we asked whether this change in the expression of 27 that we are inducing by treating this either the ex vivo preparation or, in this case again, the alveolar epithelial cells, attenuates the inflammatory response to a stimulus, whatever that is. And in this study, we treated cells with IL-1 beta, which induces an increased expression of IL-6 and IL-8, and we treated these cells with the inhibitor of microRNA 27 or the mimic, and we showed that the treatment of the cells stimulated with IL-1 with the inhibitor of microRNA 27 was associated with decreased inflammatory response. This is the IL-6 produced by these cells stimulated with IL-1, and if they are also treated with the inhibitor of microRNA 27, the release of IL-6 is less. This proves, or this suggests, that microRNA 27A has a pro-inflammatory role, because when I inhibit its expression, the inflammatory response is less. We also studied the effects of the modulation of the expression of this other microRNA, 146A, and the treatment of these cells with the inhibitor of this other microRNA, 146, was associated with increased inflammatory response. So this suggests that this microRNA has an anti-inflammatory role, because when I inhibit its expression, the inflammatory response is greater. And the same findings were found when we measured IL-8 in the same cells, alveolar epithelial cells treated with IL-1 beta, and the inflammatory response decreased by inhibiting microRNA 27, and the inflammatory response increased, in this case by measuring IL-8, by inhibiting the expression of microRNA 146. So this could certainly be a new therapeutic target, and experiments are ongoing right now in our laboratory to try to prove that this actually happens also in the ex vivo model and eventually in the in vivo rat model of Willi, and this could certainly open new avenues for treatment of this syndrome. So like the take-home message of this talk would be that the clinical criteria that we use normally for the diagnosis of ARDS designate multiple phenotypes. Doesn't designate just one phenotype within that umbrella of the clinical diagnosis, but multiple phenotypes that do not certainly share the same pathophysiology, biomarkers, and treatment. Secondly, biomarkers of the essential characteristics defining the specific phenotype of ARDS, which is an increased alveolar permeability and the presence of diffuse alveolar damage at the histological examination, are needed. We have to do more research to identify these biomarkers that allow us to identify clinically patients with a clinical pathological entity, not only acute inflammation, but also the formation of diffuse alveolar damage. And thirdly, that in our experience, and this is our line of research in our laboratory, microRNAs are potential new therapeutic targets that are being studied right now and that are promising for future, eventually also studies in humans. Thank you very much.
Thank you, Dr. Lorente, for this interesting lecture about the new targets in acute lung injury. And we don't have doubt about the contribution of your findings in the trials you enroll in this moment. And we are in the session number 6 in the lung challenges. And I want to introduce to you the next lecture about the winning in long-term mechanical ventilated patients. This lecture is presented by Dr. Oscar Peñuelas, who is from Hospital Universitario de Getafe en Madrid, quien es parte del equipo de medicina intensiva in the Hospital of Getafe, and investigator del CIBER, de enfermedades respiratorias. Welcome, Dr. Peñuelas. Well, we have at the end of the session the questions and discussions.
Okay. Good afternoon or good night, everyone. Thank you very much for the invitation to participate in this symposium, and especially to Pablo Cardinal. So let's start a presentation. As you may know, the importance of the prolonged mechanical ventilation patient is quite interesting because taking into account this systematic review published in Lancet Respiratory Medicine, you can see that the probability of death of these patients, despite the prolonged period of mechanical ventilation that they have received, still is around 50% of all of them, meaning that all the efforts that you make during the ICU stay has this impact on this kind of patients, because even the 1-year mortality is less than 50%. So taking into account this systematic review, you can say that the 1-year mortality, taking into account 124 patient studies, is around 59%, and the sub-analysis in 29 studies with high methodology, 1-year mortality is around 62%, and the follow-up in terms of long-term mortality, it's 69%, and home discharge rate is 19%, and successful winning is around 50%. So despite of the severity of the mechanical ventilation, these patients still have 50% probability of survival after 1 year of follow-up. And how important is this problem to our patients? How many patients do we have in such condition? So taking into account the international study of mechanical ventilation carried out in 2016, and using the definition of prolonged mechanical ventilation according with that, with this consensus, meaning that prolonged mechanical ventilation longer than 14 days, it's around 12% of patients that receive mechanical ventilation longer than 12 hours, and if we define prolonged mechanical ventilation longer than 21 days, it's still not very high, but still quite important. It's around 5% of those patients. And what about the mortality? If you see here, the ICU mortality considering prolonged mechanical ventilation 14 days is around 40%, and hospital mortality is still 42%. And if we consider ICU prolonged mechanical ventilation longer than 21 days, still ICU mortality is 47%, and hospital mortality is 57%. So even from observational studies, we can say that those patients that receive mechanical ventilation longer than 20 or 14 days still have a likelihood ratio of death around 50%. So they are a very clinical challenge to handle this situation and provide them the better outcomes to survive longer. And what about the weaning period? So we have seen that prolonged mechanical ventilation has an impact of ICU mortality or clinical outcomes, but also patients with longer period of with discontinuation of mechanical ventilation has an impact. This sub-analysis published some years ago in the American Journal of Respiratory and Critical Care Medicine from our group, so that if we take into account the classification of weaning as easy weaning, where the patient is successfully extubated after one attempt of discontinuation or one attempt of spontaneous breathing trial, difficult weaning, those patients that need at least 3 attempts of spontaneous breathing trial and less than 1 week to be successfully extubated, and finally prolonged weaning patients that need longer than 1 week or more than 7 attempts to be successfully extubated. You can see that still those patients with prolonged weaning, are around 6% of those patients, and the mortality, the ICU mortality, is significantly higher compared with patients with easy weaning and difficult weaning. But not only the classification is important, because also we were able to demonstrate that longer than 7 days of mechanical ventilation has an impact of the ICU mortality, in ICU mortality. You can see here how ICU mortality adjusted by severity, diseases, age, and the reason to start mechanical ventilation and the duration of mechanical ventilation itself. You can see that it remains quite stable until day 8, where goes up, meaning that we need at least 6 days to figure out what's the problem with the patient that cannot be successfully extubated, implement those strategies in order to avoid this long period of discontinuation of mechanical ventilation, and then have more chances to get the patient alive from the ICU. If we take into account the results from the last study of international study of mechanical ventilation that include 32 countries, more than 500 units, ICU units, and more than 26,000 patients longer with the need of mechanical ventilation longer than 12 hours, you can see how the proportion of patients classified according with the international classification of weaning is quite stable in terms of prolonged weaning patients that keep around 5% of the total amount of patients, independently of the severity of the patient. You can see here the bar graph where the severity is quite the same, around 40 points of SAPS scale, and the prolonged weaning patients still are quite similar. So how do we define winning failure. Winning failure is a combination, usually it's a combination of the failure of the spontaneous breathing trial plus or extubation failure during a short period of time. This failure, winning failure, could be caused by several reasons, as you may know. For example, exacerbation of COPD during the spontaneous breathing trial may induce the failure of the spontaneous breathing trial or the extubation failure. The cardiac failure also has a strong association with the winning failure. Neurological complications during the course of winning period, like delirium or coma, are very, very strongly associated with the failure of winning. The combination of the ICU-acquired weaknesses, or more recently also called myotrauma, which involves also the ventilator-induced diaphragmatic dysfunction. And finally, much less frequent, is the upper airway obstruction. So all these causes, clinical causes of winning failure, has an impact in during the period of winning, and has an influence to get the patients or successfully or failed extubated. In this sub-analysis that we carried out some years ago from the international study of mechanical ventilation, we tried to get or to perform a predictive model for ICU acquired weaknesses. So we took all the patients included in the study, that were 4,157 patients, and were classified according with the development of the ICU acquired weaknesses, defined as a development of tetraparesis areflexic when the patient was awake. So in this scenario, we report that from these 4,100 patients, we had 68 patients with the definition of ICU acquired weaknesses. And in terms of clinical outcomes, we understood after propensity score analysis that the winning failure, defined as the need of reintubation during or within 72 hours, was a PER difference of 22%. So the patient that developed ICU acquired weaknesses had more probability to have winning failure. Also, in terms of ICU mortality, we saw a significant difference between the patients that had ICU acquired weaknesses compared with those patients that not. Actually, the ICU mortality in patients that developed ICU acquired weaknesses was 31%, and the PER difference was 10%, which is quite clinically significant. Another factor that we have taken is about the ventilator-induced diaphragmatic dysfunction, and how can we predict the success of the spontaneous breathing trial and figure out if the patient is able to be successfully extubated. So in this observational and prospective study carried out in the 3 ICUs from France, from the group of Arnaud Thiel, they include 191 patients with mechanical ventilation and high risk of reintubation, and they define those patients that were older and had a duration of mechanical ventilation longer than 7 days. So at the end of the spontaneous breathing trial, they perform bilateral diaphragmatic ultrasound to define the diaphragmatic dysfunction according with the thickening fraction and the excursion, the diaphragmatic excursion, and the primary endpoint was the extubation failure, defined again as the need of reintubation within 7 days following extubation. The findings that they got is that the diaphragmatic dysfunction is not able to discriminate the patients that were successfully extubated compared with those that need reintubation. Neither the thickening fraction or the diaphragmatic excursion was able to discriminate the patients that fail actually the spontaneous breathing trial and fail also the extubation. So in terms of clinical outcomes, patients that are diagnosed of ventilation-induced lung injury still have a chance to be successfully extubated, despite of the data from the echo, the ultrasound, the diaphragmatic, the ultrasound. But one very interesting finding that they have is that the most important clinical sign to discriminate extubation failure was the definition of the cuff strength. You can see that those patients that have a very weak cuff strength were more likely to be reintubated within 72 hours. But how do we perform the spontaneous breathing trial in patients with prolonged mechanical ventilation? Well, if we take this randomized clinical trial published by the group of Martin Tobin with Amal Jubran, you can see that they carry out a randomized clinical trial comparing spontaneous breathing trial developed with a tracheal mask compared with pressure support. And here you can see that in those patients that were randomized to the spontaneous breathing trial performed with the tracheal mask had shorter duration of weaning period and were successfully disconnected from the ventilator more frequent than the group that received pressure support. Unfortunately, they were not able to find another difference in terms of ICU length of stay or ICU mortality. So, taking into account all this information, still I think that this very simple scheme is able to help us in the decision, in the clinical decision making every day, daily, at bedside, to know if the patient is able to be extubated independently of the severity of the disease, of the period of the mechanical ventilation that the patient has received. So the most important thing is considering the favorable evolution of the reason to start mechanical ventilation, and then to perform daily screening to detect the criteria for weaning. If the patient meets these criteria, perform the spontaneous breathing trial, either with the T-tube or pressure support or lower pressure support ventilation during 30 minutes. It's quite enough. If the patient tolerates the spontaneous breathing trial and the patient have effective cough and is still quite awake, so go to the extubation. Otherwise, just try to identify the reason of failure, and during that process, still performing daily SBT, either with T-tube or gradual reduction of pressure support ventilation. So, if we remember the first scheme where we had the patient that was able to or was going to have a failure, weaning failure, we can administrate bronchodilators in case of COPD exacerbation. In case of cardiac dysfunction, the negative fluid balance is very important for those patients. In case of the development of neurological complications such as delirium or agitation, so it's very important. Or we have quite good evidence of the implementation of sedative protocols in order to avoid oversedated patients contributes also to the to decrease the likelihood ratio of weaning failure. Also, taking into account the consideration of the ICU acquired weaknesses, the protocols of early mobilization during mechanical ventilation also is able to let the patients be successfully extubated. And finally, in case of upper airway obstruction, a cycle of a short period of glucocorticoids also is included in the new guidelines of weaning. In conclusions, we can say that long-term survival in patients with prolonged mechanical ventilation is around 50%. The duration of weaning is independently associated with clinical outcomes. Spontaneous breathing trial is the best approach for discontinuation from mechanical ventilation. And in case of weaning failure, the early identification of the factors related with the failure may contribute to improve clinical outcomes. So, thank you very much. No se lo escucha, Manuel.
Manuel.
No.
Hola, hola.
Now we hear you.
Okay. Thank you, Dr. Peñuelas, for this interesting lecture about the challenge in the weaning process. We have a lot of patients with these problems in the moment of weaning, and your lecture is beautiful about the main important issues in taking account in these kind of patients. The next lecture is for Dr. Ricard Ferrer Roca, who show us the lecture about the management of fungal infections in lung transplantation. Welcome, Dr. Ferrer Roca.
Hola, buenas tardes. ¿Me oyen bien?
Sí, yo lo escucho perfectamente.
Vale.
Perfecto.
A ver si pueden ver mi presentación.
On the screen? Not yet. Now we do. Can you see it? Yes. Muchas gracias, buenas tardes. Gracias en primer lugar por la invitación y felicidades por el gran éxito de esta jornada. Mi tema hoy será la gestión de la infección fúngica en el trasplante pulmonar. Así que voy a empezar con un caso clínico, un hombre de 36 años con fibrosis quística, candidato a trasplante pulmonar, también diabético. El día 0, el paciente tiene una insuficiencia respiratoria grave, también hemoptisis y ECMO, que es lo que va a llevar a este trasplante de pulmón.
So he was submitted to bilateral lung transplantation and he stayed in ECMO for 3 extra days before weaning of the ECMO. The clinical course after this transplant was unfavorable. So the patient have some episodes of infection, some of them with septic shock, prolonged antibiotic treatment, Clostridium difficile colitis, some episodes of pancytopenia, especially lung infections with ventilator-associated pneumonia. So it was not an easy patient, and of course some of this infection in a patient with cystic fibrosis was by multi-drug resistant microorganisms. The question is that on day 40 the patient have again another episode of septic shock. In this case was a medastinitis that need source control and again broad spectrum antibiotics as empirical therapy, but in the cultures and in the blood cultures and the samples from the surgery, there is the growth of blastobotrix. So that patient needs treatment, prolonged therapy with liposomal amphotericin B in combination with micafungin. The clinical course was good, but the ICU stay was very prolonged and the hospital stay was very prolonged. And in fact, the patient remains colonized by Aspergillus and extremely resistant Pseudomonas. And the patient was discharged after 11 months in the hospital and 9 months in the ICU with stability. But this is an example of a patient with infection, with fungal infection after lung transplantation. So fungal infections are not uncommon. The epidemiologists say that we have like 750,000 invasive candidiasis in the world annually, 300,000 invasive aspergillosis, and for other infections are less common, like mucormycosis, 10,000 per year. If we look to the number in Spain, for example, the numbers are around 1,300 episodes of candidemia in the ICUs, and the total, including the candidemia outside of the ICU, is close to 4,000 per year in Spain. But you can see that the ICU is representing 1/3 of this invasive candida infection, something similar for candida peritonitis. For invasive aspergillosis, in Spain we have 1,300 per year, and the most common location is ICU together with the oncohematological ward. Mucormycosis, it's around 20 per year. I guess that these numbers are infraestimated because I think we have some more cases per year, but this is the published numbers and the numbers we have. So for those infections, lung transplantation is a risk factor. These are the risk factors for invasive aspergillosis in ICU patients. And you can see here the lung transplantation is an intermediate risk factor, and solid organ transplant in general is a low risk factor. So both solid organ transplantation and lung transplantation are risk factors for invasive aspergillosis. So the reason for that is that those patients are high risk because they are going to receive immunosuppression and other predisposing factors, but also the lung is more exposed to Aspergillus infection, of course, very different from other solid organ transplantation like kidney, liver, pancreas, or heart. So aspergillosis is more predominant in patients with a lung transplantation because the lungs are more exposed to the spores of aspergillus. So this is well known that immunosuppression in lung transplantation is a way of it's an acquired cellular immunodeficiency. Here you have a description of the mechanisms that are implied together with the T cell depletion, also deviation of the lymphocyte population, and also some alteration in the receptors for cytokines. So the combination of these mechanisms, of course, are going to put the patients at risk of invasive fungal infections. But there are others we have to take into account. For example, that there is a high interaction between the antifungals and the immunosuppressive drugs. So we have to take into account. Also, some of the drugs we are giving for avoiding rejection are going to induce neutropenia. Also, you know that those patients have high risk of reactivation of cytomegalovirus, and there is a close relationship between reactivation or infection by this virus and, again, invasive fungal infection. And there is a phenomena that is more recent, which is that we have some organ donors that are coming from regions where there is endemic mycosis. So this is something that we are also taking into account recently. And most of the patients with lung transplantation at the end develop diabetes, which is a risk factor for mucor. So the combination of all these factors make that transplantation, especially lung transplantation, is a risk factor for those type of infections. So we can describe those infections between the opportunistic infections, which have universal distribution. Here we have Candida aspergillus and Cryptococcus, mucor also, and Fusarium, and those infections that are endemic, which patients with lung transplantation are going to reactivate those infections. This is the main reason. But as I said, some donors are going to transmit this fungal infection to the receptors if the donor are coming from areas where this endemic infection is have high incidence. So here you have the distribution of invasive fungal infection according to the organ which is transplanted, and you can see in the middle of the slide that for lung it's a little bit different from the other organs, being Aspergillus #1, Candida #2, and Thigomycetos #3, and the rest are miscellaneous. So the lung is different from the other organs because of the risk of Aspergillus. And here you have a description of areas in the world where some fungi are more prevalent. For example, in Africa, you have more histoplasmosis. In Asia, you have more penicillosis, and in North America, you have more coccidioidomycosis, and in the Latin area, you have more paracoccidioidomycosis. So those fungi are more predominant, are endemic in those areas. So if we are attending a patient who receives a viscera coming from a donor from this area, so this patient is going to have risk factors for those infections. So the emerging fungal infection are those who have lower prevalence, like between 7 and 10% of the invasive fungal infection cases, but the incidence is growing, and in this group I have included mucormycosis, fusarium, and scedosporium. Of course, and this is general, we don't have information coming from clinical trials of treatment of this infection in the setting of transplant, because this is the prevalence is very small. So we have to go for registry like the Fungiscope registry or the Recitra registry. Here you have the timeline after transplantation. You can see here that tracheobronchial aspergillosis is frequent very recently after transplantation. Also, this primo infection, but endemic fungi, is also frequent during the very early phase of transplantation. Then before 6 months, we have Candida, and then we have lung invasive aspergillosis and cystis pneumonia during this period between 6 months and 1 year. And then a long-term zygomycosis, cryptococcus, and reactivation of endemic fungi could appear 2 years after lung transplantation. So this is a review we wrote a couple of years ago, assessing the antifungal prophylaxis in solid organ transplantation. And you can see here that for lung transplantation, we recommend, in this case, nebulization of liposomal formulation of amphotericin B as the prophylaxis. So those infections are so frequent in this setting that patients are going to need prophylaxis at least for 1 year. In general, in all solid organ transplantation, those patients are going to have prophylaxis for pneumocystis jirovecii, and also the prophylaxis for Candida is not recommended in patients with lung transplantation. So what about Candida in patients with solid organ transplantation, especially in lung transplantation? So I would say that the management is quite similar for the rest of the patient. Incidence is around 2%. Is more common in solid organ transplantation, abdominal solid organ transplantation, especially pancreatic transplantation or liver transplantation, but also patients with lung transplantation can have Candida infection. Preventive therapy is done based on Candida score. You know that blood cultures have a sensitivity between 50 and 75% for Candidemia. So in most cases, we are combining blood cultures with molecular techniques for diagnosis, like Mannan antibodies, which are high specific for Candida, or beta-D-glucan, which is not specific, but is sensitive and can be used for ruling out invasive fungal infection. So this is the pathophysiology. You have to take into account the density of colonization, the integrity of the gut mucosa, and how is the immune status of the patient. And here you have the risk factors. and most of them are frequent in lung transplantation. So most of them are going to receive antibiotics, broad spectrum antibiotics, so colonization is frequent. Parenteral nutrition in the post-op period of lung transplantation is frequent because most patients are going to have gastroparesia, so they are going to need parenteral nutrition, so this is again a risk factor. And of course, immunosuppression, neutropenia, renal failure, hyperglycemia are also risk factors. So more exposure to risk factor and more duration of the exposure and more number of risk factors are going to increase the risk of invasive candidiasis. And candidemia, you know, that is able to produce dissemination into deep tissues, especially important endophthalmitis and endocarditis. Treatment in those patients, again, there are no trials specific in patients with transplant, so we have to take the general recommendations, which is to use echinocandin as first-line therapy. And because of interactions with immunosuppressive drugs, amidolafungin is the drug of choice in this setting. Remember to do the echo for ruling out endocarditis, and also the endophthalmic examination for ruling out endophthalmitis. We also recommend, if you have the suspicion that if the central line is the reason for the candidemia, to remove all the central lines and to do the serial blood cultures until clearance of blood cultures in those patients with candida. So invasive aspergillosis is number one in lung transplantation. The incidence could be up to 3.5% of all patients with lung transplantation. There are two forms, at least or three forms, which is after colonization we can have tachybronchitis. We also can have infection of the suture with high risk of dehiscence of the suture, and also we have the classical lung infection we can see in other settings. So these are the most common form of infections. Which are the risk factors for lung transplantation in the early phase? These are the risk factors. So if we have ischemia in the suture or the placement of a stent in the suture, this is an important risk factor. Rejection, of course, single lung transplantation, and aspergillus colonization. These are the risk factors in the early phase. In the more or less phase is chronic graft dysfunction. For the diagnosis, high resolution CT, even or MR are the radiologic techniques that we have to use if we have the suspicion of invasive aspergillosis. Allosign is exceptional in this setting. It's more typical in hematological patients. The isolation in the respiratory tract samples of aspergillus have low predictive value. Have to try to distinguish between colonization and infection. In some cases, in those patients, we are going to have lung biopsies because we needed that for the diagnosis of rejection. So sometimes the diagnosis could be confirmed with the lung biopsy, and the use of biomarkers have better sensitivity if are done in the BIL. So a cutoff of 0.5 of galactomannan in BIL is highly specific in this setting, and the specificity is much lower if we are doing that in plasma samples. Pan-Aspergillus PCR by now is only used in research and not routine use in the clinical setting. So in most of the cases, we are going to do a diagnosis of probability with the combination of the clinical symptoms and the radiological image together with the microbiological association and the galactomannan in the BIL. And in some cases, but this is the frequency is lower, we are going to have a diagnosis which is going to consider definitive because we are going to have a biopsy with IFA and tissular damage in the biopsy. But this is not very common, as I say here. And I also want to stress that in general, in critical patients, the definition for a diagnosis of probability is a little bit different than the criteria, the international criteria in a more general population. So this is the criteria we are using for the diagnosis of aspergillus. Again, a combination of clinical symptoms, which include fever, failure of antimicrobial therapy, together with hemoptysis, or also worsening in gas exchange, together with the radiological images and the combination of risk factors. So this is the definition we are using in most of the cases. So this is the allosign that I said is not very common in patients with lung transplantation. The therapy, the prophylaxis, as I said, our preferred prophylaxis is nebulization of lipid formulation of amphotericin B, but others consider the formulation of the desoxycholate amphotericin B or mycophangen could be also as an alternative. But especially in the early phase that we want to protect the sutures for Aspergillus infections, we consider that nebulization of liposomal amphotericin B is the optimal. If both of therapy, the general guidelines recommend voriconazole or isavuconazole. They are recommendation A1 for both. And if we have to go for combination, then it's combination of voriconazole with echinocandin. In most of the cases, it's cascofangin in these cases. So in solid, it's important to stress also time to therapy, because in solid organ transplantation, delay in therapy, as also in hematological patients, but especially in solid organ transplantation, delay in therapy has worse outcome. So the therapy voriconazole, 6 milligrams per kilo twice daily, 6 to 12 weeks of therapy, and in tracheobronchitis by Aspergillus, the combination of voriconazole with nebulized amphotericin B is also a good combination, and sometimes we need to do bronchoscopies to clear the debris and the fungal walls. Remember that the pharmacokinetics of voriconazole could be a little bit erratic, and sometimes we have to do TDM to monitor the levels of these compounds. And again, we have to check the interaction, especially with the levels of immunosuppression, and sometimes we have to reduce the dose of the immunosuppression up to 75%. What about mucor? The frequency of mucor is less. There are some different phenotypes, especially the pulmonary phenotypes that could have a mortality close to 50%. The cerebral phenotype could have a mortality of more than 70%, and the sino-orbital phenotype, like this one here, it's also can be seen, and also the mortality could be high. In the diagnosis in most of the cases requires to have sample from the infection. So in this case, the treatment is a combination of surgical debridement in most of the cases, together with liposomal amphotericin B. And some information about the scedosporium. I'm going to finish because I think I am running out of time. Scedosporium is representing 25% of the infections not caused by Aspergillus. I'm going to finish with my key points. The main differential diagnosis radiologically is going to be with cancer in patients with lung transplantation. So the challenges for diagnosis are very important. So we have some difficulties in demonstrating the presence of the fungi in the tissue, and the validity of the biomarkers, as I said, in immunocompromised patients, is low. There are pharmacological interaction between the antifungals and the drugs we are using for therapy. So that are my conclusions. Definitive diagnosis in lung transplant can be difficult, so we are going to use a diagnosis of probability in most of the cases, but in some cases we are going to have the biopsy. The biomarkers, we have to use BAL if we want to test galactomannan, because in blood the sensitivity is very low. Up to 40% of the patients with lung transplantation and invasive fungal infections are going to have negative cultures, so the diagnostic is challenging. the incidence of emergency pathogen is increasing and are associated with high lethality, especially for mucor. But in general, those infections have high mortality. The duration of therapy should be individualized, and in most cases is going to be long. And another challenge is the pharmacological interaction with the immunosuppression that makes that we have to go for TDM, of course, for immunosuppression, but also for the antifungals. And of course, if those patients are submitted to ECMO or those patients are submitted to continuous replacement therapy, we have to consider that some of these drugs are going to be absorbed by the oxygenators in the ECMO and are going to be also hemofiltrated, like the azoles. The azoles are hemofiltrated in most of the cases by the hemofilters. So that makes that the dosification of these drugs in this setting is also very challenging. Thank you for your attention, and I think we have some time for questions now.
Thank you, Dr. Ferrer, for your lectures, for interesting.
Well, I don't know what happened with Manuel, the chairman of this session, but Dr. Ferrer, I received a question from a resident, a Mexican resident, Julio Suarez. He mentioned what happened in undeveloping countries where the sensibility from the azoles is quite high. He asked if it is recommended to increase and to escalate or maintain the azoles. What do you think?
I think so. In that cases, I think you should go for combination therapy with an echinocandin with caspofungin. Should be the best option, and also the new triazoles are also. Could be an option. I don't know how is the resistance to the new triazoles in Mexico, but I think that maybe a combination using new triazoles with caspofungin could be an alternative.
Thank you very much. Dr. Lorente, could you come here, and Dr. Peñuelas, I have one question for each of you. Dr. Lorente, we have a question from Puerto Rico, and they mention, or really they ask, what is the clinical relevance of the different phenotypes in ARDS patients?
Well, so far, this is really a key question. The interest is, for several reasons. I would say that the first one is for the design of clinical trials. So because this could be one or probably the most important reason why previous clinical trials on the use of pharmacological therapy in ARDS have failed, because we are treating a heterogeneous population of patients that have different phenotypes. Although we make the clinical diagnosis of ARDS, then under that umbrella of ARDS diagnosis, there are different patient populations. Only about half of them have actually the histological manifestations of ARDS, which is a DAD. So it's really very interesting to define the phenotypes either based on histology, which is more challenging, or based on clinical or and biochemical variables that define phenotypes, like in the study by Calfi and collaborators. So for the design of clinical trials is really a key issue. If you test the effects of, for instance, an anti-inflammatory drug, you want to identify patients who have a pro-inflammatory response, which is one of the phenotypes by Calfi, and not the other type of patients.
Okay, thank you, doctor. We have another question for Dr. Peñuelas. This question comes from Mexico, and our colleague asked about what is the most important thing, and we do in case of mechanical or ventilator-induced diaphragmatic dysfunction. What we can do in this kind of patients?
Thank you for the question. It's a very relevant clinical question, I think, in case of a patient with failure of weaning. So far what we have identified is the association of ventilator-induced diaphragmatic dysfunction with failure of extubation. But still we have no tools, we have no clinical tools to prevent or to treat the ventilator-induced diaphragmatic dysfunction. From the preventing point of view, we have some drugs that have been already proven like 10, 20 years ago, which are the methylxanthines, like aminophylline, that have shown already some beneficial effects in preventing the ventilator-induced diaphragmatic dysfunction, and also most recently from the group of Leo Henks in the Netherlands, they have shown some very beneficial and protective effects of levosimendan in preventing actually the ventilator-induced diaphragmatic dysfunction. However, in case of patients that actually have developed the ventilator-induced diaphragmatic dysfunction, it's quite difficult to arrange a strategy to avoid or to treat the complication, the myotrauma. But I think that trying to implement the respiratory physiotherapy is quite interesting alternative in order to enhance the total vital capacity and the maximum inspiratory pressure, like training for the diaphragm, and implement those strategies in the daily clinical routine, clinical practice of those patients could be very, very interesting.
Okay, thank you very much. And the last questions for this session is for Dr. Ferrer, and this question comes from Mexico. Our colleague Julio Suarez, who is resident of the last year of critical care.
Manuel, we have done this question. We are finishing.
Sí, Pablo.
We have done this question. Ya hemos hecho esa pregunta, ¿vale? Ya no hay más preguntas.
Okay. Thank you very much for the session, and we are proud for this event, and I want to make a special recognition for this event to Dr. Pablo Cardinal for his support and his effort to make this event a reality for lung enthusiasts. Thank you very much.
Thank you for this fruitful discussion.